phones or keep it on silent mode. Thank you. Without further ado, we will begin with our plenary speech and lecture. For this, we would like to hand over the ceremony to our facilitator for today, is Dr. Siti Nur Ainasi from Hospital Sultan Aminah Johor Bahru.
Okay, Assalamualaikum and good morning. Thank you to our Master of Ceremony. Good morning, everyone. Are we ready today? Okay, once again, welcome to the National Conference of Nuclear Medicine 2022, Johor Bahru. I am Siti Nur Ainasi and I'll be facilitating our session 2. Okay, which will be Skeletal team. Alright, thank you for attending this conference physically and also for our virtual participants. Okay, we will have our Q&A and discussion at the end of the session, and I encourage everyone to write down your questions. Okay, if time permits, we will answer the question asked by the virtual participants as well. Okay, without further ado, I will start to introduce our first speaker for today is Dr. Mohd Fazrin bin Rohani. He is a nuclear medicine physician at Hospital Kuala Lumpur. Okay, he had his medical degree from Penang Medical College in 2010 and had procured a master degree in nuclear medicine from University Science Malaysia in 2019. He then obtained his fellowship of Asian Nuclear Medicine Board FNB in 2020. Dr. Fazrin has authored and co-authored several manuscripts in local and international journals. He is also an invited reviewer for several local and international journals. So without further ado, floor to Dr. Fazrin. Thank you.
Thank you for the kind introduction and thank you for the invitation. Assalamualaikum and very good morning to everyone. I'm Dr. Fazrin from the Department of Nuclear Medicine, Hospital Kuala Lumpur. And the topic of my presentation today is quantitative analysis of SPECT on bone scintigraphy. So this is the outline of my presentation. Introduction, SPECT-SUV in bone scan, SPECT-SUV in DJD or Degenerative joint disease, bone metastasis, its application in therapy response, and lastly conclusion. So usage of molecular imaging techniques in both single photon emission computed tomography and positron emission computed tomography has indeed improved diagnostic accuracy. Both modalities rely on the predetermined amount of tracer that is being admitted to patient to assess metabolic activity in certain regions of the body. So these acquired images can be assessed visually, can also be assessed quantitatively. So to perform a quantitative analysis of a certain region of interest, either on SPECT or PET, some hurdles need to be overcome, and these include photon attenuation, photon scatter, as well as partial volume effect. So unlike PET, the technology for quantification in SPECT is rather slow and complex, and SPECT is conventionally regarded as non-quantitative. SPECT images are being assessed based on relative intensity and not radial tensor activity in absolute units, i.e. standard subject value, and this has created inter-observer differences in terms of image reporting, especially among us physicians. For SPECT SUV, with the advancement of hybrid imaging techniques in both SPECT-CT and PET-CT, the SUV measurement, which is commonly used in PET studies, is made possible in SPECT-CT due to a host of factors. These include improvement in detector performance, development of image reconstruction algorithms such as ordered subset expectation maximization or AWESOM, and a co-registered CT image used for both attenuation and scatter correction. So from these factors has rendered quantitative SPECT to be a feasible method to be used clinically, which is comparable to the established quantitative PET imaging. And it is expected that a quantitative SPECT-CT will have an enormous effect on the practice of modern practice in nuclear medicine. So this is on SUV. So SUV is basically tissue concentration of tracer measured by scanner within the volume of interest of your eye, normalized to the dose injected, as well as body size. Of course, there's a few types of body size, namely body surface area, lean body mass, and body weight. Of course, in body weight, the SUV is assumed by the injected activity is assumed to be spread uniformly over the entire body, but we know that this is not true. Of course, in obese patients, this will cause in overexpansion of SUV, especially when we use body weight. So to counter for this, the usage of lean body mass has been proposed, and especially in obese patients, and this is deemed to be more accurate. And the usage of lean body mass is also important in patients whose weight changes substantially post-therapy. And to add, lean body mass is not affected by variation of body weight. So there are different types of SUV, namely SUV max, SUV mean, and SUV peak. For SUV max, basically measures the highest value within the VOI. It is independent of the VOI size, more reproducible and less inter-observed variability. For SUV mean, it integrates information from multiple voxels. It varies based on the voxels included in the average, and of course, this will have inter and intra-observer variability. And lastly, SUV peak, which incorporates the average SUV values in a group of voxels around the voxel with the highest activity. So compared to SUV max, SUV peak is less affected by image noise, and has the highest reproducibility in SUV quantification, especially in small lesions. But nonetheless, the most commonly used SUV is SUV max, based on body weight. So SPECT SUV in one scan is basically a calculation of assessed radioactivity concentration in a TC9 which is being expressed in SUV. Of course, like PET, parameters for SUV calculation includes timing of injection, the amount of injected activity, the residual activity in the syringe, timing of acquisition, as well as patient's height and weight, depending on which body size they are going to use, either BSA, LBM, or body weight. So the patient's values are then normalized based on the timing of the tracer injection, as well as image acquisition time by the software provided by the vendors. This will differ based on the cameras that we have. So this is just an example of how we do SPECT-CT SUV calculation. This is a planar bone scintigraphy on a patient with prostate cancer. As you can see, there's uptake at the L3 vertebra. So we did a SPECT-CT, and this uptake corresponds to skeletal bone lesion, and we are able to draw the volume of interest around the lesion, and subsequently the VOI was measured, and value was 65.4. So below is the values that obtained from the calculation. So this is the SPECT SUV based on the SPECT SUV max based on body weight for this patient. Of course, this can also be done in other lesions such as DJD or degenerative lesions, as seen here, another case of prostate cancer can see uptake at the left L5 vertebra, which corresponds to intervertebral disk space, and with areas of end plate sclerosis, and VI was drawn, and the SUV was obtained at 20.72. So similar methods can be applied to the normal bones, as can be seen on your right, which is the quantification for the normal vertebra. So when we talk about SUV in normal bones, of course, our main reference is sodium fluoride PET, F18 sodium fluoride PET. So there's a study by Win and Apariki in 2014, which measures the SUV in normal bones. So this is the values obtained from Win and Apariki. This is based on SUV max based on body weight. As you can see that the average SUV max was obtained for cervical, thoracic, and lumbar vertebra, femoral and humeral head, mid-sternum, as well as the parietal bone. You can see that the highest amount of SUV is seen at the thoracic and lumbar vertebra. This is due to the fact of because this region bear the mechanical stress, which express the interleukin 11, which in turn leads to increase in osteoblastic differentiation, and hence increase in bone turnover, hence the higher SUV. So whatever study that is being done on sodium fluoride can be replicated on a SPECT-CT bone scintigraphy. Because on normal bones, there are a number of studies that have been done on the normal bones, mainly in the spine. This study includes Kakoven, Kanita, Kuji, Tabuta, Rohani, Huang, and Zhang. As you can see that most of the regions include the lumbar vertebra, and which is a common area for bone metastasis. When we compare the SUVs based on body weight between SPECT SUV and PET SUV in normal bones, you can see that the value does not differ much, as shown here, when we compare to the study by Win and Apariki published in 2014. So to add, a study by Keta et al. In SUV max of the vertebra based on body weight was found that it has the lowest variability compared to other SUV, mainly BSA and limb body mass. And in addition to this, a study by Wang et al. Published in 2020, SUV based on body mass, based on body weight, was found to be positively correlated with bone mineral density measured on DEXA scan, and they concluded that it can be a tool for clinical quantification of bone metabolism in patients with osteoporosis. But of course, they need a larger sample size to validate their findings. Because there are other studies which measures the normal bone in SPECT-CT SUV. This study by Tezuka and Ogura published in earlier this year, which measures the normal bones in the head and neck. Another study by Wang et al. Published in 2018, which measures the SUVs of the pelvis. And last year, publication by Yongsin et al., which measures the normal SUV of bone in the knee joints. So SPECT SUV in DJD and bone metastasis, when we interpret our bone scintigraphy, of course, identification of bone metastasis is often confounded by lesions, especially in the spine, sorry. And a bit of a recap in terms of pathophysiology in the JD. As we age, there are changes in the intervertebral disc, results in the narrowing of joint space, as well as joint instability. This leads to inflammation and bone remodeling, which leads to calcification of the disc as well as osteophyte formation. So in bone metastasis, there is a disruption of balance between osteoblast-mediated bone formation as well as osteoclast-mediated bone destruction. So this process will cause increase in ultrasound uptake in our bone scintigraphy. So several studies have looked into SUV as a quantitative marker in differentiating between these two lesions, either benign DJD or bone metastasis, in both PET and SPECT. Just quick recap on the CT criteria published by Sapir et al. In the 90s, which define DJD on the CT component of our SPECT-CT on SPECT, which the definition is increased uptake corresponds to facet joints and plates within osteophytes or around the joints on CT, whereas for bone metastasis, uptake is corresponds to lytic, sclerotic, or mixed lytic circulation on CT. Of course, when we look on the study on to look into these two lesions, we first look at the PET. There's a study by Mansor et al. Published in 2015 on F18 sodium fluoride PET-CT involving prostate cancer patients. This study compare the lesions in DJD and bone metastasis. And what I can summarize on this study is the average SUV max based on the body weight is lower compared to bone metastasis at 22.6 compared to 63.4 for bone metastasis. So as you can see the box plot on your right, you can see that the SUVs for both lesions varies, ranging from 11.2 to 188 for bone metastasis and 2.6 times 49.9 for Degen. And there's an area of overlap between these two lesions ranging from 11.2 to 49.9. Of course, whatever that's been done on sodium fluoride PET can be done on our SPECT-CT. And there are several studies that have looked into this differentiation. So these are the SPECT-CT studies to look into the difference between DJD and bone metastasis. The study by Khoo, Tabuta, Rohani, Zhang, and Gerje, latest one by Gerje, published in June this year. As you can see that the SUVs are generally lower compared to sodium fluoride PET. And for DJD, you can see that it ranges from 10.26 to 60.73, which is much lower compared to bone metastasis, ranges from 24.7 to 40.9. Tak ada, dia tak gerak. Okay. Some studies even propose cutoff point to differentiate between DJD and bone metastasis. This ranges from 16.6 to 20. As you can see that most of the studies involve prostate cancer patients, apart from Zhang in 2021 and Gerje. Zhang has a mixture of prostate and breast cancer patients, whereas Gerje had breast cancer patients. As you can see that, as you know that breast cancer has osteolytic bone lesions, hence lower uptake on our bone scan, hence the lower SUV. This can be reflected in the average SUV as a cutoff point from the study by Gerje et al. In addition, study by Gerje et al. Uses SUV max based on lean body mass compared to other studies. We know that SUV max based on lean body mass is lower compared to body weight, hence the lower amount of SUV compared to other studies. So from the studies by both PET and SPECT, there is a wide range of variation of SUV between DJD and bone metastasis with a considerable overlap. And all studies concluded that SUV max for bone metastasis was significantly higher compared to DJD. However, the usage of SUV max alone cannot be used to differentiate between these two lesions, but it can improve our diagnostic accuracy in the two groups, as you know that bone metastasis will have higher uptake compared to DJD. So speaking of sodium fluoride versus SPECT-CT SUV, is there any study that compare these two modalities is there a head-to-head comparison for these two? The answer is yes. In a study by Avola in 2019, in 52 patients comparing the SUVs in both HDP SPECT-CT and sodium fluoride PET-CT, involving 26 breast cancer patients and 27 prostate cancer patients. So these patients underwent both HDP SPECT-CT and sodium fluoride PET-CT within 14 days of each imaging modality. So a total of lesions, 231 lesions were being analyzed, with 129 being metastatic and 102 being benign. This is just an example of the sample being obtained by Avola. As you can see that the SPECT SUV is lower compared to PET SUV, and they obtained the SUV peak, SUV mean, as well as SUV average. SUV max, sorry. So from this study, it was concluded that the SUVs obtained from HDP was found to have strong correlation with sodium fluoride PET-CT. This is based on the scatter plot shown here for all SUV max, SUV peak, as well as SUV mean. And the reason of higher SUVs in PET compared to SPECT is due to the poorer spatial resolution in SPECT compared to PET, partial volume effect which is more apparent in SPECT compared to PET, better pharmacokinetics of sodium fluoride compared to HDP, and a higher lesion to bladder ratio in sodium fluoride compared to HDP. Nonetheless, was concluded from this study that SPECT is an applicable tool for the clinical quantification of bone metabolism in osseous metastasis in breast and prostate cancer patients. Now we move on to the therapy assessments of using SPECT SUV. I'll be sharing 3 cases by Ketajima et al. In the clinical usage of SPECT SUV in bone scintigraphy. So the first case is a 10-year-old female presented with painful swelling at middle portion of right lower limb, biopsy-revealed periosteal carcinoma. 2 courses of chemotherapy were given, which include methotrexate, adriamycin, and cisplatin. On your left is the pre-chemo X-ray. You can see that X-ray thickening covered by broad-based soft tissue mass. And on your right, is a post-chemotherapy X-ray which showed cortical thickening eroded by a broad-based soft tissue mass. As you can see that post-chemotherapy, the lesion is getting bigger compared to the previous X-ray. So patient also had an MRI. Above is the pre-chemo MRI. Below is the post-chemo MRI. You can see that on the post-chemo, they had done T1 and T2 weighted imaging. You can see that there's a growing hypointense inner part and associated outer part on T1 imaging, as shown by the arrow here, and a growing mixed hypo and slight hypointense inner part and hypointense outer part lesion on the T2 imaging. So both X-rays and MRI shows a growing lesion. But when we did a SPECT-CT bone, the uptake is more or less the same or slightly reduced compared to the pre-chemotherapy imaging. So above is the pre-chemo, below is the post-chemo. Of course, when you do a quantification, you can see that from the graph, the authors have obtained the SUV max, SUV peak, SUV mean, MBV, and TBU. All of the parameters have reduced compared to the pre-chemotherapy bone scintigraphy. And a little bit on TBU, which stands for total bone uptake. It is an index of active bone metastatic burden calculated by SUV mean times metabolic bone volume. To be frank, I'm not that familiar with TBU, but this has been reported by a few publications by the Japanese for the past few years. So in this case, the tumor tissue of the tuberous was removed, and HPE revealed pathological grade 1 tumor with 20% area of necrosis, which is compatible with non-complete response after chemotherapy. So in this case, the quantitative SPECT-CT was considered to reflect therapy response by providing information on the histologic response prior to surgery by means of SUV, which contradicts to the findings from X-ray and MRI. So case 2 is a 63-year-old female with pathology proven mandibular osteomyelitis, and patient also had left maxillary sinusitis. Bone SPECT-CT revealed focal and intense uptake in the left mandibular molar region, reflecting a bone inflammatory activity by mandibular osteomyelitis. There's also uptake in the left sinus due to sinusitis. So this is a pre-therapy bone scintigraphy. The patient had another bone scan after hyperbaric therapy and antibiotic treatment. As you can see that the second bone SPECT-CT revealed decreased uptake in the left mandibular molar region, which reflect suppression of bone inflammatory activity. So a third bone scan was done, I think 6 months after the second bone scan, and this showed a mild decreased uptake in the left mandibular molar region. Of course, when we do quantification, you can see the trend of reducing in activity of the tracer as the patient has undergone several therapies. So in this case, the quantitative bone SPECT-CT is useful in the evaluation of bone inflammatory activity and as well as tumor response in patient with mandibular osteomyelitis. And the third case is a 64-year-old female with lung cancer post-surgery, complaint of right hip pain. As you can see, bone scintigraphy was done to evaluate for bone metastasis. Uptake is seen at right femoral head, and mild uptake is seen at the left ribs, localized to the left and 8 ribs on SPECT-CT. So subsequently, patient underwent radiotherapy to the right femur, and the chemotherapy was also given. So when you compare the first and second bone scan, you can see that uptake is reduced on the right femoral head, increased uptake in the left ribs, give new uptake in the right ribs, sternum, spine, and pelvic bones. So this is the SPECT-CT, which shows the findings that I've mentioned earlier. So when we do quantification, you can see that all of the parameters for the right femur has reduced, and the parameters for left ribs has increased significantly, which indicates disease progression. So in this case, the two quantitative bone SPECT-CT images showed good response of the femur head from the RT, and a progression of other bone metastasis in spite of chemotherapy. So quantitative SPECT-CT in this case proved that non-invasive has proven to be non-invasive and useful modality in the evaluation of bone metastasis as well as treatment response. Of course, there are other publications which look into non-oncological cases, its impact on the therapy. This include medical-related osteonecrosis of the jaw. This was published by Okoy in 2020, and also in the evaluation of patients in rheumatic joint disease. So to conclude, quantitative SPECT-CT offers a more standardized method in quantitative analysis, which reduce inter-observer differences. It can be used in treatment response evaluation, patient follow-up, inter-patient comparison. This ensures consistency in follow-up. And last, quantitative SPECT-CT is an applicable tool for clinical quantification in bone metabolism. With that, thank you.
Thank you very much, Dr. Fazrin, for the interesting discussion. Okay, next we move on to our first virtual speaker. Okay, he is Dr. Alex Khoo Ho. Okay, Dr. Alex is a consultant nuclear medicine physician at Penang Adventist Hospital. He graduated from University of Malaya and pursued his postgraduate studies in nuclear medicine from University Science Malaysia. Dr. Alex is a board certified by the Asian as well as the European Board of Nuclear Medicine. He is an active speaker at the state and national levels and has published numerous peer-reviewed journal and newspapers articles over the years. Okay, are we ready? So without further ado, please welcome Dr. Alex with the lecture of Inconclusive Skeletal SPECT-CT. What's next?
A very good day to everyone. Firstly, thank you to the organizers for the kind invitation for me to give a lecture in this nuclear medicine conference. I apologize for not being able to attend the conference physically, although I really love to. Now, coming back to my lecture today, Inconclusive Skeletal SPECT-CT, what's next? So when I first received the topic, I was wondering, what's next? So it's definitely the moans and the groans of the nuclear medicine physicians when dealing with bone scans. I suppose many of you will agree with me. In the past, when we only had gamma camera, we had to send our patients for x-rays and CTs. Can you imagine all the hassle and the difficulty in correcting the lesions? Fortunately, for most centers now, we have SPECT-CT. Straightforward cases are easy, but when you have an equivocal lesions, how do you conclude? So before I proceed with the lecture, allow me to briefly go through the history of bone scan. Since the discovery of radioactivity in 1896, there's been significant progress in the discovery of various radioactives, such as fluorine-18, technetium-99, gallium-68, lutetium-177. And the ability to detect radioactive activity is of utmost importance. Once we learn how to unlock the target and map the properties of this radioactive, the sky is the limit. Sodium fluoride was discovered much earlier than the technetium-99m MDP and is by almost a decade. Sodium fluoride remained a wonderful bone scan agent, but unfortunately its production and use has been put on hold for the past 2 years, pending a review by our country's regulatory body, the NPRA. In the past, scans were done using rectilinear scanners. As you can see the image on the left, the images are definitely off by the current standards. It's boxy and we can barely make out the outline of the body. So the two images on the right shows the bone scans that we all know. What's the difference between the two? It is the quality of the scan. The resolution of the gamma camera has improved over the years. So looking at those images, then one might wonder, is nuclear medicine unclear medicine? So is it really unclear medicine? So let's look at this imaging of the hand. So the imaging of the hand has evolved over the years. Looking at the imaging done by Wilhelm Röntgen, and you can see the conventional X-ray we have now, the CT and the CT reconstruction. These are the bone scans of the hand. And we look at the hand on the left, it is imaged using a conventional sodium iodide detector, whereas the one on the right is imaged using a SPECT-CT detector. Despite using the same radio tracers, the differences seen is due to the detector use. Solid-state detectors such as SPECT-CT has higher detection efficiency for gamma rays and good energy resolution. So is bone scan still relevant? We have so many imaging modalities and even radio tracers which are quite disease-specific. Then again, bone scan can detect as little as 5% change in bone turnover, whereas radiograph and CT, there must be at least 40 to 50% mineral loss before you can detect any lucency in the bone. Now, what are bone scans for? Is it for cancers alone, orthopedic cases? In most instances, bone scans are almost always ordered for cancer cases. So before we proceed, we need to know which cancer spread to the bones. There's no point doing a bone scan if the cancer that we are dealing with hardly metastasized to the bone. Let's have a look at this table, which shows the incidence of bone metastasis at postmortem. As we can see, breast and prostate cancers commonly metastasize to the bone. In fact, bone scan is part of the imaging staging investigation for prostate cancer. Knowing which cancer spread to the bone is important. Knowing the nature of the bone metastasis is equally important. Some cancers are predominantly sclerotic, some are predominantly lytic, and some are a mixture of both. Let's look at the bone remodeling hemostasis. There's always a balance between the osteoclastic and osteoblastic activity. And the balance is disrupted either by cancer or fracture or etc. So how are we able to determine where the balance lies? So the balance lies, it can be more bone resorption or bone formation. So the diagram that we see here illustrates the available imaging modalities that for us to use. We have X-ray, CT, MRI, bone scintigraphy, SPECT, and FDG PET. And mind you, this was done, this paper was published in year 2004. Conventional X-rays and CTs are most widely available and they are fastest to perform. This imaging can tell us the lesion is sclerotic or lytic or a mixture of both. Then again, bone scan actually highlights the metabolism and not the anatomy. Sometimes things are not as simple as it seems. Not all bone scans are due to cancers. Let's have a look at this prostate cancer patient. The posterior view of the planar bone scan shows a focal uptake at the right side of the L1 vertebra. As you can see here, looking at the bone scan alone, you might think that this is just due to degenerative changes. But when you do a SPECT-CT, you know that this is actually sclerotic and is due to metastatic disease. So another patient with prostate cancer, he has a focal lesion in the vertebra, and in this limited view of the bone scan. And when you do a SPECT-CT, what you can see is actually he has an anterior osteophytes with subchondral sclerosis at the L2, L3 vertebra, which is actually due to degenerative changes. So let's see this 64-year-old lady with breast cancer. She has undergone mastectomy and chemoradiation. This is the initial staging bone scan done 5 years earlier. It looks normal. And the restaging bone scan shows a focal uptake at the right 7th rib. So is this a metastasis? So when we do a SPECT-CT, we notice that there's a thickened cortical bone, which is actually an old fracture. So nonetheless, we need to remember solitary bone lesions account for 21% of metastatic bone disease in breast cancer, but only 6% occurs in the rib. Okay, so this is another case of a lady with a bone scan with breast cancer. You can see a very subtle lesion here, as shown by the arrow. There is a subtle uptake at the left femur. So is this a metastasis? So when you do a SPECT-CT, what you notice that the CT, you can see that there's a spotty ossification. This is in keeping with bone infarct. So this patient does not have metastatic disease, but instead a bone infarction. So this is a case of a patient newly diagnosed prostate cancer, Gleason 4+4, PSA of 20. What do you think about the images? Are those images highlighted by the arrows due to degenerative changes? What will you do? Then again, you do the SPECT-CT. And what do we see? We actually see a lesion here which is actually not degenerative, but is actually a radiologically occult bone metastasis. So is planar bone scan imaging alone sufficient in our daily practice? Well, this is an example of a lady in her 60s with a right scapular pain. She had left mastectomy and axillary clearance in 2017, followed by chemoradiation the following year. At this point of time, you can see there's a focal uptake here at the T4 vertebra. So what does this lesion mean? Is it metastatic or is it degenerative changes? Does it answer the question of right scapular pain? So when we did the SPECT-CT, what we noticed is actually here she had an expansile lesion here, and the focal uptake was seen on the right side, on the left side, and this is the expansile lytic lesion on the left side. This is another lady with breast cancer. The bone scan shows uptake here as highlighted by the number 1, 2, and 3. So is this compression fracture involving lesion number 1 and degenerative changes involving lesion 2 and 3? So when you do a CT, what you notice is these lesions are all sclerotic and these are in keeping with metastatic disease. So let's look at this lady with breast cancer. She did a bone scan and this shows a focal uptake at the right sternoclavicle junction. So without any further investigation, you will probably think that this is just degenerative changes. But when we do a SPECT-CT, what we notice is the CT component that's actually sclerotic lesions at this area, and this is actually in keeping with metastatic disease. So this is another case of a lady with breast cancer, and the whole body planar scan shows generally a homogeneous uptake with a facet joint uptake here in the cervical spine, and it's generally unremarkable. But when we do a SPECT-CT, what we notice is actually there's actually a focal uptake at L4 region, and the CT component actually shows multiple lytic lesions, and these lesions are not shown on the bone scan. This is a scan of a patient with prostate cancer. You can see this patient here, the L3 lesion. There's not much significant uptake, and after treatment, there's also not much uptake. But on MRI, you can see that actually there's uptake there's a lesion here on the MRI, and upon treatment, the lesion has resolved. So you must remember that bone scan is not the scan just for the bone. Marrow changes are not seen on bone scan, so we need to look into other imaging modalities. So looking at this patient with breast cancer, you notice that there's this planar image scan shows a artifact here at the subclavian catheter. Okay, and also a fracture here at the left rib, 8th rib. And when you do a SPECT-CT, what you notice is actually there's a lesion here, which is a focal lesion in the scapula here. Okay, and the lesions also in the vertebral spine, as you can see here. So these lesions are actually metastatic. These lesions are metastatic lesions. Whereas the one here is actually a degenerative changes. So what do you see in this scan of an elderly lady with newly diagnosed breast cancer, T1N1? So the bone scan, on this scan, you look like as if there's no it looks unremarkable. But when you do a SPECT-CT, what you notice is actually there's a focal intense uptake at the right pelvic bone. So the corresponding CT shows sclerotic changes, and this is in keeping with metastatic disease. And when they did the MRI, it confirms that this is actually a sclerotic lesion, indeed a metastatic lesion. So this is a planar scan of a patient with prostate cancer. You can see there's two hot foci in the right, third, and fourth rib, and you think that this is most likely due to fractures. Okay, and this is clearly seen when we did the SPECT-CT. You know that this is actually a fracture. Anything else that you can see? So when the SPECT-CT was done, it included the pelvic, and you notice there's a pelvic bone uptake. And this pelvic bone uptake, when we analyze the SPECT-CT, we notice there's a hot foci there, and this is in keeping with metastatic disease. This is another planar bone scan for a 51-year-old lady with locally advanced breast cancer. Look at the focal lesions in the ribs and the left femur. So there are these two lesions here on bone scan. But when you do a SPECT-CT, you can see the lesions much better. And when you do PET bone scan, you can see there's actually two lesions here on the femur which was not seen, and there's another lesion here on the thorax which was not seen, thoracic vertebra which was not seen on the SPECT-CT, SPECT images. And when we do a MRI, these lesions are all confirmed on MRI, which suggests this is a metastatic disease. So which bone scan to use? We already seen technetium 99M MDP and PET bone scan. So which one will you use? So this is imaging of a patient, same patient. This is using a conventional technetium 99M MDP bone scan. This is using a PET bone scan. So you can see that the PET bone scan, you can see more lesions on the PET bone scan, and the resolution is much better compared to the technetium 99M. So what's the difference between these two modalities, and in comparison also with the FDG PET? Number one, the bone scan has lower radiation, but the time taken to do the scan is much longer with bone scan, the conventional bone scan. For PET bone, you will only take 1 hour of uptake time, and then we can scan the patient within 20 to 30 minutes. What about the specificity and sensitivity? As we put the PET bone as a benchmark 100%, we notice that the MDP only reached sensitivity of 92% with a specificity of 82%. Let's look at other uses of bone scan. So is bone scan useful in fractures? Well, usually X-rays and CT are the norm and easiest to perform. So is there any role of bone scans? So in fractures, we tend to use it for non-accidental injuries, especially in children, but we can also use it as a screening test for missed fractures in severely injured patients. So patients with polytrauma would have undergone skeletal survey, but sometimes lesions can be missed. This is shown by the study by Lee KJ et al. That 61.8% of patients with multiple trauma had missed fracture detected on bone scan. The most frequent location was in the ribs. So what else is bone scan useful? So it can be used to in patients with painful hip or knee prosthesis. So there are 10 situations that can cause pain other than loosening and infection. So what are they? They are referred pain, patellofemoral pain syndrome, fractures, fissures, abscesses, hematoma, bone insert behavior, heterotrophic ossification, greater trochanteric pseudoarthrosis, osteoarthritis extension in a knee with unicompartmental prosthesis, systemic disease with bone involvement. So let's have a look at an example. A 35-year-old man with right hip prosthesis present with sudden lameness. Okay, what you can see you can see some uptake here at the right hip, but what else you can see on the CT is actually you can see a right psoas abscess, and the underlying cause was actually the traumatic contact between the prosthetic screw and the muscle. So similarly, there's another case of a 22-year-old student who was involved in a car accident and had a fracture of the right posterior acetabulum. He had a fixation of the posterior acetabulum and now complains of pain in the right leg. So the referring physician was worried about a vascular necrosis of the head of femur. So he couldn't do MRI because of the plating, and now what's next? So we did a 3-phase bone scan. The flow phase was normal. the blood pool shows some increased uptake at the right hip region, and the delayed bone scan does not show any significant uptake. So what we saw actually is that there were no evidence of avascular necrosis, but there was a traumatic contact between the prosthetic screw and the left external of right contact between the prosthetic screw and the right obturator externus muscle. So is SPECT-CT useful in painful foot and ankle? Well, yes, and this article by Ilsing et al. Reviewed 8 studies describing the diagnostic value of SPECT-CT in foot and ankle pathology based on patient data. So the combined analysis showed that the change of management and improved diagnosis occurred in 48 to 62% and 40 to 79% of patients when compared to other imaging modalities. So symptomatic improvement due to treatment based on SPECT-CT finding occurred in 92% of patients. So it was concluded that SPECT-CT is useful when diagnosis based on other imaging modalities is inconclusive, or when treatment based on these modalities does not lead to the desired symptomatic improvement. Here's another example of a patient treated with internal plate fixation of the distal fibula due to Weber B fracture. However, he reported persistent pain around the entire ankle joint. Plain radiograph, as you can see here, and the CT scan did not show any definite abnormalities, which can explain the persisting pain. Fortunately, when we did the SPECT-CT, you can see that there's actually a hot uptake here, and this uptake is at the syndesmosis. So this patient was treated with a dual screw syndesmosis fixation and a graft on the distal tibula, and the pain resolved. So is there any role of a bone scan in dentistry? Well, yes, bone scan can be done for evaluation of mandibular condylar hyperplasia. So this is a CT reconstruction of asymmetry of the mandible. You can see here, the right mandible appears to be shorter vertically compared to the left. So if you look at the posterior volume reconstruction, you can see the left condyle is actually larger. So what's the use of bone scan in this case? So bone scan actually help the clinician to determine the activity of the disease. So it quantifies the differences between the left and the right condyle, and if there's more than 10% differences, it may indicate actively growing condylar hyperplasia. Why is it important to know whether it's active or not? It's because you need to consider in inactive status, conventional orthognathic surgery can be recommended without condylectomy. However, in active status, active growth potential of the affected condyle should be removed. So what's next? So as I mentioned earlier, bone scan is not one and all. Sometimes we might miss other lesions, and hence choosing the right imaging might be helpful. So in this case, a patient with high-risk prostate cancer, a Gleason 5+5 with a PSA of 115, you can see extensive bone metastasis. And there were also lesions in the liver and lymph nodes which were not picked up by the bone scan, of course. So he underwent chemotherapy and he responded well, as shown by the FDG PET-CT here. You can see there's multiple liver lesions and also the bone lesions. And following further treatment, he actually improved, and all the bone lesions started to disappear, and also the liver lesions. This is another case of a patient with prostate cancer, Gleason 4+5, diagnosed 5 years earlier and had local radiotherapy. He was recently noted to have a rising PSA level. So he did a bone scan, and the bone scan was unremarkable. However, there was paracable nodes, which was not active, of course. Then he was started on enzalutamide, but after a year, the PSA started to rise again. So they sent for PET-CT, and what we noticed actually, they had a metabolically active paracable nodes. And these nodes were subsequently radiotherapy. So we have another patient here, an 80-year-old who initially presented with back pain. He was found to have pathological fracture of the T11 and T12 vertebra and multiple lytic lesions in the bone. So during the workup, he was also noted to have PSA of 20, and they proceeded to do a thrust biopsy, and it came out as a prostate adenocarcinoma 3+3. So does this explain the severity of the disease? PSA of 20, Gleason 3+3. So you look at the CT scan. These are all the CT scan. You can see lytic lesions. So Will a bone scan be helpful? Or what about 18F FDG PET-CT? So in the end, this patient actually had a PSMA scan. So what happened is actually we detected only a few lesions, bone lesions, which was PSMA avid, and the rest was not avid, and the rest was actually due to multiple myeloma. So this patient actually had a concurrent prostate cancer and multiple myeloma. Let's have a look at this CT scan in a patient with prostate cancer. What do you think? So which one is metastatic? Is it A or B? So A looks metastatic because you can see there's a lesion here, a bit sclerotic, and B, it doesn't look like there's anything there. So you proceed to do gallium PSMA in a prostate cancer patient, as we assume we do. And you can see actually the CT positive, and this is also gallium positive. Whereas in this lesion, which was CT negative, when you do, it was gallium positive, PSMA positive, and these are actually all skeletal metastasis. So can gallium PSMA PET replace bone scan? So the idea now is it probably would, because it's superior, and in future this might change the whole how we manage our prostate cancer patients. So let's look at the neuroendocrine tumors. So this is a 68-year-old lady with metastatic neuroendocrine tumor of the small bowel. So you can see here she actually had multiple liver lesion metastasis and also in the bone. Okay, but the CT did not show any bone metastasis to the left iliac bone. When you do a bone scan, you can see all these bone lesions which were highlighted by the DOTA-TOC scan. And when the PET-CT was done, it was also confirmed. So why you're asking, why is this patient doing so many scans? Well, this is a research, so that's why they did all this scan. Another study from that scan, from that research, a 78-year-old lady with neuroendocrine tumor of unknown primary. So you can see she had multiple diffuse bone metastasis, but the CT scan did not show, only showed part of the bone mets involvement, but MRI showed diffuse involvement, and so did PET-CT. So the take-home message from the talk today, we need to choose the right imaging for the right problem. Bone scan is not the imaging for all bone-related issues. So we need to choose which one is the right one. So we need to correlate clinically with other imaging modalities such as CT and MR. Okay, so marrow changes are better seen on MRI. Okay, the last but not least, the eyes do not see what the mind does not know. So we need to keep abreast of the latest development and to consult colleagues, whether from within the fraternity or outside. With that, thank you.
Thank you, Dr. Alex, for the informative lecture. Okay, shall we move on to our next lecture by Dr. Muhammad Syahir bin Mansor. Okay, let me introduce Dr. Muhammad Syahir. Dr. Syahir is an assistant professor at Advanced Medical and Dental Institute, AMDI. He obtained both his Bachelor of Health in Medical Radiation Science and Master of Science in Medical Radiation Science from University Science of Malaysia with a specialization in nuclear medicine physics. He was appointed as a postdoctoral research associate in Malenkov Institute of Radiology, Washington University in St. Louis Medical Center, USA from 2019 to 2020. Dr. Syahir has published numerous research articles in peer-reviewed journals, and his main area of research interest is quantitative PET-CT and SPECT-CT imaging, PET-CT kinetic modeling, and internal dosimetry. Okay, with that, Passing the floor to Dr. Syahir.
A very good morning to all. So first of all, I would like to thank the organizer. In inviting me to be part of this conference. So today I would like to discuss a bit regarding the how we can improve the performance of a SPECT-CT system in nuclear medicine. Okay, first we can start with the gamma camera principle. Basically, the SPECT itself is just a technique using the same gamma camera. So first from the patient, right? From the patient, emit the single photon, and then detected by the detector, converted into the electrical pulse. Okay, so we can see basically this part has been revolutionized based on different detector system. The conventional still using the crystal and PMT, and then they move to photodiode array, and then we come up with the semiconductor array. Okay, so for the photodiode still using the crystal, but they replace with the instead of using the PMT, they use the semiconductor. But if you go for the high sensitivity system, of course it has a drawback in terms of applicability for the higher energy radionuclide. Okay, so to begin with the principle of SPECT-CT, basically we have multiple projection going throughout around the body, and then at the end it will be converted to in term of sinogram. So you can see this is a 0 degree position, 180, and come back to the 360 degree. Okay, so this is the basic how the system capture the data from the body. You can see here, this is if we have a subject with like a lesion here, you can see the white part is the detected. So this is the sinogram. So the sinogram is used in terms of reconstruction afterward. Okay. So the clinical use of SPECT-CT consisted of bone scan using HMDP or HDP. For the brain, we have multiple tracer, Hampau, EDC, Trodet 1, ioflupine, IOD 123. And then for the lung, MAA, cardiac, maybe, liver, also MAA, and DTPA for the kidney. Okay. So, talking about the factors that affecting SPECT-CT, because we need to understand that there are multiple factors that are contributing to the final reconstructed images in terms of the quality of the image, so that we can tackle area by area. So we start with the acquisition from the emission part and also the CT part. Also for the physical, which is we have scatter, resolution, attenuation, and so on, and also a motion. And then the last part is the image reconstruction. So each part need to be tackled so that the final SPECT-CT image can be optimized. So if we look at the term optimize itself, we have to make the best of most effective use of a situation. So we have a lot of room for improvement, but in this idea is that the system itself must pass the QC, of course. Otherwise, it's not. We have to repeat the QC. Okay, so we go for the SPECT-CT acquisition. So in terms of injected activity, if we have less injected activity, of course, the image will be degraded. In terms of acquisition, you have to optimize this as well, whether you want to elongate the acquisition time or not, and then the number of steps, the energy window, and then the type of acquisition, whether it is a step and shoot or the continuous mode. So basically, we have to juggle around between image quality and acquisition time. If we wait for a longer time, of course, you will get the better image quality, but at the same time, the patient comfort must be take care as well. So for the acquisition time, there will be effect in terms of reduced activity. Of course, when the activity reduce, of course the low count statistics. And then if we have optimum injected activity, of course, with the optimum scan time, we can capture the high count statistics, and then the use of broader energy window. So if we use a broader one, of course, you will be including a lot of scatter into your sinogram. So in terms of the acquisition, the doctors need to taken care in terms of the registration between CT and also the emission, because the CT itself providing the attenuation information for the emission to be reconstructed and corrected. So if we can see here, there is a hypoperfusion here, and then when we change the co-registration between CT and emission, you can see the image become normal. So this is some sort of contributing factor for misdiagnosis. So check the co-registration. Okay, so let's say we have a SPECT, okay, and then we have true distribution activity within the patient or phantom, okay, and then we want to know how much is the measured activity distribution, because at the end of the day, we want to correlate the true between the measured and the true, right? So, but there is a lot of factors that can make it inconsistent result or inaccuracy, which is first the attenuation, second is the scatter, the resolution, whatever measured activity at the end. Okay, so after we capture the emission data, of course, we do the reconstruction. Okay, during the reconstruction, this time whereby we have to compensate back whatever counts that we lost during the acquisition from these factors. Okay, so we have the attenuation correction, scatter correction, resolution correction, and also a motion correction. Finish with the reconstruction with the inclusion of all reconstruction correction. We get the measured count distribution. So we assume this to be corrected from all physical factors that affecting the emission of the data of the emission, and then because in SPECT right now we still gather the measurement in terms of counts, but we want to know the activity, right? And then we have to calibrate the system so that it can convert the counts to activity with the high accuracy. Of course, a new machine or modern machine right now, they already included the calibration factor in the system itself, so that the tools that are provided by the vendor can calculate all those SUV based on from the count distribution. Okay, we can start with the attenuation correction. You can see on the left is the NAC, non-attenuated correction of the uniform phantom, and then the right one is the based on CTAC, okay, reconstructed using the same method, okay, and then we can plot a profile, the horizontal one. You can see here there is a low activity here, but when we include the attenuation correction, you can see here it almost 40%, 30 to 40% error of the activity from the non-attenuated NAC image. So we can see here, if we plot the vertical line, vertical profile, you can see the same pattern whereby non-corrected suffer from the count loss due to the attenuation that are not corrected. After we do the correction, of course, we gain back the activity or the counts that we lost. So second is the scatter correction. As we know, let's say we have the technetium 99M. Of course, we have the photo peak window, all right? And then the scatter happens from the start of zero energy towards more than 140, okay? So how we can projection or the counts that captured within the photo peak window, okay, and then we have the part of scatter with the weighting factor of 1, of course, because we only take the down scatter. In terms of the acquisition data, in terms of sinogram, and then you can see here, this is the final corrected from scatter. You can see it is more contrast compared to the initial one, okay. And then the same thing after we correct for scatter correction, and then we proceed with the reconstruction. In terms of resolution correction, different vendor, they use different name. For GE itself, they use a resolution recovery. Okay, so the resolution for SPECT basically affected from the okay. So the resolution loss in SPECT-CT basically contributed from geometric response function, whereby the closer the source to the detector, the better the resolution. Okay, and then the intrinsic, which is within the detector itself. If we have a thicker detector, of course, the spectrum or the peak, the response of the detected activity will be broader. Okay, we have a septal scatter function, whereby the photon detected, the photon it has happened the scatter first and then detected in the detector. This also giving a broader spectrum, and also septal penetration. This happen for the high energy radionuclide such as iodine. So include with all these factors, we call it the collimator detector response function, and from this we continue with the reconstruction. Bear in mind that those correction need to be applied so that you can get the an accurate activity distribution at the end of the day. So this is the motion correction. If you can see the projection, okay, you can see when one detector going through the body, right, and then sometimes there is a mismatch within one frame of a sinogram, like this. You can see here. So there will be a motion in this particular frame that will be contributing to also the hypoperfusion of the reconstructed data. So this also need to be tackled down so that you can get the best activity as much as possible, as accurate as possible. So this is the basic of image reconstruction. As we can see here, one subject forward project into the sinogram, okay, and then with the filter back projection reconstruction, we just back project into an image space. You can see here there is a blurring that occur when we back project the sinogram. So this is the unwanted quality of the image. So they come up with a better technique in terms of reconstruction, which they call it MLEM, or iterative reconstruction. We start with the initial guess, which is a blank sinogram, okay, because this particular sinogram you have gathered from the subject, right? So to start with, the initial guess blank, and then the measured projection of the sinogram, you have to apply all those physical factors correction, such as scatter attenuation and so on. Okay, so we have the corrected measured projection, and then we compare between the initial guess and the corrected one, and then we project back into the image space. Okay, update the image, and then we get a new sinogram, which is a better in terms of quality, and then this process will be repeated based on how many iteration that you set. So the better the higher the iteration number, basically will give you a better resolution, but in the trade-off with the high statistical noise. So in terms of if you evaluate the data in terms of SUV max, so the higher the iteration will give you more prone error of quantification. So over iteration amplify the statistical noise, and hence hampered the quantification of the data set. So in terms of this is our data. So basically we have, this is a product one. If you look at the data, so we have a caudate, putamen, and also a background, the rest of the braid. If you can see, there is a different in terms of reconstruction. We have the OSEM completed, corrected with the attenuation correction, scatter correction, and also resolution recovery. And then the second one is also the OSEM, but we didn't include the resolution recovery on the for the green line. And then the last one is the filter back projection with the attenuation correction and also the scatter correction. As you can see, it shows better in terms of structure quantification compared to other reconstruction. I want to highlight that a lot of center, they basically didn't apply the correct or the needed correction. And then if we focus on the quantification, it will be problematic if we didn't apply the whole set of correction. So this is a paper focusing on the quantification of product one. Okay, so we optimize in the study. We optimize in terms of reconstruction part, using the phantom and also the clinical data set. Okay, the strategy is to simulate activity reduction by 25%, and then at the end of the study we come up with the 25% activity reduction is possible. Okay, because we apply the optimum reconstruction settings in our data. So this is at least the optimum iteration number, and also the subset. Okay, so if you can see here, we could retain the quantification error, okay, within reduction of 25% of the data set. Okay, you can see here the quality is still acceptable in terms of quantification, at least. So to summarize my talk is, first, we have to tackle or optimize the acquisition part, and then the physical part as well, and also the reconstruction. At the end of the day, we will get the highly accurate quantification. So this accurate quantification will be determining the accuracy of the dosimetry part. If you focus on the dosimetry, if you focus on the kinetic modeling part, this also will give very accurate data rather than under-corrected data set, and also response to therapy if you use a SPECT-CT before, pre and post therapy. Yeah? So to finish up, this is you can see structure without function is a corpse. Okay, function without structure is a ghost. So they are very complementary for each other, such as SPECT-CT, yeah, or PET-CT. Okay, and then I would like to I would like to invite anyone that are interested in our project, because we receive seed money from the USM in molecular imaging for Alzheimer disease, and also the liver malignancy research program, which is targeting the biomarkers discovery correlated with functional imaging and structural images, AI-powered disease diagnostic in the future, and also multimodalities treatment approach, which is the external beam, SERT, and also brachytherapy. Thank you.
Thank you very much, Dr. Syahir. Now I would like to invite Dr. Syahir, so Dr. Fazrin, to be seated in front for Q&A session. And I suppose Dr. Alex is online as well for Q&A session. So any question from the floor or virtually? Yes, Dr. Salita.
Can I ask Dr. Alex? Oh, virtual. So, kat mana nak cakap tu? Okay. Hi, Alex.
Hello.
Okay, Alex. I just wonder, because I saw in one of your presentation in which a lady with a breast cancer, the planar bone scan was normal, yet your SPECT-CT shows some uptake in the right pelvic bone. So I just wonder, do you do all SPECT-CT for all your patient, even though the planar is normal? And if you do, what is your is it from head to toe or from which area?
Okay. I used to do backbone. I just had my SPECT-CT installed this year. So I used to do backbone, and as you know, backbone means we have to do the whole body. For SPECT-CT nowadays, I tend just to do it on the regional sites. And if there is sites of complaint, then I'll look into it. I'll do SPECT-CT on the specific site. So regarding cases where, like, the prostate cancers, just now I did show some areas that you incidentally picked up those lesions. So those lesions, sometimes we will tend to miss it during our planar imaging. So as a routine, no, because SPECT-CT takes a very long time to do. I'm sure if you do a whole body, it will take a very long time. If you are in a busy center, like in the government setting where you have so many bone scan patients, it's quite unlikely that you're able to do a SPECT-CT for all patients. So it's basically, for me, it's a targeted SPECT-CT.
Okay, thank you, Alex. Can I ask Dr. Fazrin? This is a yes or no answer. Can you differentiate between degen and bone metastasis with the quantitative measurement of the bone scan in the SPECT-CT?
The answer is no.
You can see that from the slides earlier. There's an overlap between SUVs in both degen and bone metastasis. But of course, if you do a serial bone SPECT-CT, you can see the trend of the uptake, which can help us in seeing whether whether that thing is bone metastasis or not.
So in other words, we still need a CT component as well.
Yes, true.
Okay, thank you very much.
Dr. Fazrin, do you, at least in your report, do you write your SUV values if you're looking for the trend, as you said earlier?
So in practice now, we don't do SPECT-CT for all patients. We only do SPECT-CT for indeterminate bone lesions. Of course, if you were to do for all patients, I think it will affect our workflow, and there's a limitation of our camera time. So of course, with this presentation, I think our technology is going to be more receptive on doing SPECT-CT in the future. I hope so.
Yes, Prof.
Morning. Regarding Madam's question about differentiating the malignant from benign, obviously it is the clinician's job, and CT really helps a lot. And more than the quantitation, we have NM640 where we can also do quantitation, but we don't depend on that obviously. So what we do is obviously using the CT. So the basic principle is whenever you have posterior element involvement like pedicule, we are going more towards the metastasis. When we have only facet joint involvement, obviously it is degenerative. When there is involvement of body, especially in India, tuberculosis is very common. So the involvement of purely body, there is a 55% chance for that to be tuberculosis. So we need to look into the clinical setting and the site. So involvement of pedicule only, there is an 85% chance for that to be called as a metastasis. Body plus pedicule, there is a 65% chance to have metastasis in that. Pure involvement of facet joint or transverse process, then it is more towards the degenerative. So obviously that is how we need to look into that. The incidence or the number of bone scans being done for metastasis evaluation is significantly coming down because of the usage of FDG PET-CT. But still, I think whenever there is an opportunity for us to do a bone scan, this is how we do that. And majority of the time, when the planar bone scan is normal, we do a SPECT-CT, and especially in GE, you have the combination of doing a whole body CT. But there, we mainly concentrate on the dorsal and lumbar vertebrae and pelvis. So we can add it together, and using resolution recovery, you can do it fast. And CT mainly for localization. So any normal bone scan, we are more worried. I think we should be going more towards the SPECT-CT. So this is how we approach. And the indication, obviously when it is for carcinoma breast, we need to see twice if it is a normal bone scan. And the clinical perspective is much more relevant rather than quantitation perspectives. Thank you.
Abnormal, you will just do SPECT, just to see the location first, and then you do CT, or you will do SPECT-CT straight if it's abnormal.
I think because we have a SPECT-CT, we straight away do it as a SPECT-CT. And using this whole body protocol and using resolution recovery, it is possible to finish off the 3 bed positions between 15 to 20 minutes more. So we always give 25 millicurie of MDP, and when we do a whole body, our speed is 15 centimeter per minute. In that speed, once the whole body is over, it takes around 15 minutes. You have to spend, of course, 15 more minutes or 20 more minutes, but I think it is relevant and worth.
More questions on the floor? Yes.
Good morning. I would like to ask Dr. Syahir. I'm from Nigeria, basically for SPECT, and in fact, most of our cases is cardiac cases. Okay. Then we have very limited experience in general cases. I would like to ask you about quality of image in terms of resolution and noise. In your presentation just now, you explained about how to correct the image if it is undercorrected, okay, based on attenuation, scattered motion, and resolution. So, how do we know we reconstruct, before we reconstruct, we corrected the image is overcorrected? Okay, thank you.
Thank you for the answer. So, okay, sorry, you go. Thank you for the question. Okay, so how we know the whether it is overcorrected or not, right? So basically, that's why we need to validate everything first within the phantom setup. Whether it is a cardiac phantom or if you have the Neymar phantom, which has several spheres inside, so you can use various activity with the different background settings. From that, when you apply and then apply all those correction, you can try to compare whatever the theoretical and also reconstructed activity. So from there you can see whether it is overcorrected or undercorrected. And then if you can get the it is impossible to get a zero percentage of variance in terms of true and captured, right? So at least within 5% you can say, or you want to be more lenient, you can go up for 10%. Within 10% of activity difference between whatever SPECT-CT giving you and the activity of the real phantom, then you can say it is optimum in terms of correction and also reconstruction. So yeah. So basically 5 to 10%, or you can go up for 15 lah. Kalau let's say sometimes in iodine, you basically it will give you around 10 to 15% of the error lah. Okay.
Anyone? My last question to Prof. Syahir. Actually it has been puzzling me for quite some time.
Okay.
Kenapa bila when we use semiconductor, we trade off with high energy, meaning that we cannot detect high energy, we cannot do high energy scan, right? Like ID. Why is it so?
Okay, so basically, if we have a conventional crystal with the PMT, right? Even though very high energy passing through the collimator detected and then interact with the crystal itself has stopping power actually, because that's why if you have a thicker crystal, better for very high energy photon. So the problem with the SPECT or semiconductor based SPECT-CT currently, the problem is the high energy photon will be just passing through without interact with the element in the detector. So that's why it is not optimized for high energy usage. Maybe in the future they will come up with a different kind of collimator or different in terms of stopping power for the electronic itself. Thank you.
Any more burning questions from the floor? Virtually? Any more questions from the left side? Okay, I guess we finish this session. Okay, please give another round of applause for our speakers. So with that, I'll pass the mic to our Masters of Ceremony.